starting with vitamin A topic. So vitamin A is available in two forms for human needs. First is retinoids. These are preformed vitamins which occur only in foods of animal origin. So liver being the richest source. Second are the provitamins, that are beta carotenes. These are found in vegetarian foods. And provitamins are cleaved to yield retinaldehyde, which is important for vision, and then retinol and retinoic acid. These are associated with growth. So retinoids refer to all synthetic compounds including retinol, retinal, and retinoic acid. Retinol is taken as reference vitamin A. Retinal is an aldehyde form obtained by oxidation of retinol. Retinal is aldehyde form and retinoic acid is carboxylic form. Retinol on oxidation give rise to retinal and then retinoic acid from retinal. Retinol and retinal are interconvertible, but retinoic acid, once formed, cannot be reconverted into retinal or retinol. Next is provitamin. So these provitamins are basically beta carotenes and they are commonly called provitamin A, even though alpha, beta, and gamma carotenes also give rise to vitamin A. So these are colored pigments found in colored vegetables like carrot, spinach, sweet potato, etc. So beta carotene is cleaved into two molecules of retinal in the human intestine. In human, this conversion is inefficient, hence beta carotene possesses about 1/6 vitamin A activity compared to vitamin A. So retinal is then reversibly reduced to retinol. Thus retinal and retinol are interconvertible. Retinoic acid is produced by an irreversible oxidation of retinal. Hence the two are not interconvertible. Next is absorption and transport. So food of animal origin contain vitamin A as retinol esters, while plant foods, fruits and vegetables contain beta carotene. So retinal ester are hydrolyzed to retinol and free fatty acids by pancreatic retinal ester hydrolase. After absorption, free radical is re-esterified with long chain fatty acids within the mucosal cell. Retinal esters are then incorporated into chylomicrons and passed via the lymphatics to the liver where they are stored. Beta carotene is cleaved by beta carotene dioxygenase to generate two molecules of retinaldehyde, which in turn is reduced to retinol and esterified subsequently. Liver holds 90% of vitamin A reserves, and when need arises, retinol is released from the liver and transported to various tissues in a bound form with retinol binding protein. It is believed that zinc play important role in retinol metabolism. The retinol and retinol binding protein RBP complex interacts with another protein in the blood plasma, that is transthyretin prealbumin, to form trimolecular lipoglycoprotein complex. This molecule aggregates of a relatively large size prevent loss of vitamin A by glomerular filtration. It also ensured the taking over of retinol by specific cell surface receptors that recognize this trimolecular complex. So retinol binding protein and retinol complex on coming in contact with target tissue like eye, skin, gonads, etc. binds to RBP specific surface receptors. Free retinol is internalized and RBP returns to circulation. RBP and transthyretin returns to circulation. Once the retinol makes an entry into target cells, it binds with the cellular retinol binding protein that carries the retinol to the nuclear receptors. Two families of nuclear receptors, RAR and RXR receptors, play crucial role in binding the retinol to specific DNA regions in target genes, causing their expression, that is gene transcription. This in turn results in synthesis of specific proteins that carry out ultimate biochemical functions of vitamin A, such as morphogenesis, growth, and cell differentiation. In this manner, the mechanism of action of retinol at cellular level resembles that of a steroid hormone. Retinoid receptors play an important role in regulating cell proliferation and differentiation. It also inhibits keratinization and decreases sebum secretion. This is why retinoic acid is used therapeutically in treatment of promyelocytic leukemia and acne vulgaris. Next are the biochemical functions. So main role of vitamin A is in the vision. Next is the reproduction. Then in the glycoprotein synthesis. Next is cellular differentiation and growth, including immune cells. And next is the antioxidant function. So first, starting with the role of vitamin A. Retina of the eye possesses two type of cells. Rods, these are basically required for the dim light, and they are mainly in the periphery, and these are mainly 10 million rods. And cones, these are 5 million cones, and these are at the center of the retina, and they are for the bright light and color vision. So rhodopsin is a conjugate protein present in rods and is responsible for vision in the dark, that is scotopic vision. So rhodopsin consists of protein called opsin and 11-cis retinal in its interior, acting as chromophore. 11-cis retinal is attached to opsin protein by a shift base linkage with the NH2 group of the 296 lysine residue side chain. So starting with the rod cell. So rhodopsin is present in outer segment of rod cells of retina. Rod cells outer segment has about 1,000 discs stacked one above the other. Each disc contain rhodopsin in its membrane. There is also sodium potassium ATPase pump in inner segment of rod cells, through which sodium is pumped out. The CGMP dependent sodium calcium ion gated channel is present in the outer segment. So in the dark, CGMP level is high, which is necessary to keep the channel open and allow the entry of sodium and calcium into the rod cells. So sodium ions are pumped out through sodium potassium ATPase channel in the inner segment. Closing and opening of CGMP dependent channel is associated with generation of visual impulse following exposure to light. So discs are also rich in vitamin E to prevent photooxidation of UFA present in phospholipids. Each disc has a life of about 1 month and are constantly replaced. So next is the link to ophthal. So outer segment of retinal rods containing very high concentration of long chain fatty acids, that is DHA. So fish oils are rich source of DHA. DHA is required for development of brain and retina and is supplied through placenta and milk. Being long chain DHA confers high fluidity to the membrane of outer segment of rods. High fluidity enables rhodopsin to undergo lateral and rotational movement within the membrane when activated by light photon. So there is a disease called retinitis pigmentosa. So it is a disease characterized by loss of night and peripheral vision. It is associated with abnormal lipid metabolism, low level of DHA in blood observed in patient of retinitis pigmentosa. So premature babies are more vulnerable owing to reduced activity of desaturase enzyme, which affects formation of DHA from linolenic acid. Next is generation of visual nerve impulse. So visual signal is generated due to hyperpolarization of rod cell membrane following excitation by light and generation of signal. So rhodopsin present in this membrane is bound on the cytosolic site to G protein called transducin. Like all G protein, it is heterotrimeric protein with 3 alpha, beta and gamma subunits. So T alpha subunit has GTP binding site and inherit GTPase activity. So next is walled visual cycle. The event of visual cycle begins with the absorption of the light with the formation of few unstable intermediates in the span of few picoseconds after a photon is absorbed. The initial product batho-rhodopsin is converted through a few additional intermediates into meta-rhodopsin 2, which has a half-life of approximately 1 minute. Finally, the dissociation of meta-rhodopsin 2 to opsin and all transretinal take place. During the process, opsin undergoes significant structural reorganization. The conformational change in opsin affects the resting membrane potential and initiates the remaining event in the generation of nerve impulse. Now some amount of all transretinal is converted to 11-cis retinal and the remaining all transretinal is transported to the liver via blood. In the liver cells, all transretinal is reduced to all trans retinol by alcohol dehydrogenase dehydrogenase. Then all trans retinol is isomerized to 11-cis retinol, which is then oxidized to 11-cis retinal and transported back to the retina. So 11-cis retinal recombines with opsin to form rhodopsin, and the cycle begins again. So meta-rhodopsin 2 activates the transducin, in which GDP of alpha subunit is replaced by GTP. It then splits into dimeric beta gamma subunit and monomeric alpha subunit. So active alpha subunit with a bound GTP acts on phosphodiesterase and remove the inhibitory subunit bound to it. So phosphodiesterase is activated. Activity phosphodiesterase destroys cGMP and decreases its level inside the rod cells. So low cGMP level leads to closure of sodium calcium channels in the outer segment, blocking the sodium or calcium ion entry into the outer segment. This leads to hyperpolarization of the rod cell membrane and generation of nerve impulse, which is then transmitted to optic nerve. Membrane is partially depolarized at rest and hyperpolarization on stimulation. Because membrane is partially depolarized in the dark, a neurotransmitter glutamate is continuously released. Glutamate inhibits optic nerve bipolar cells with which rod cell synapse. By hyperpolarization, the rod cell membrane, the light stops the release of glutamate, relieving inhibition of the optic nerve bipolar cells and thus inhibiting signal into the brain. So next is the termination of the visual signal. Following photoexcitation of rods, the photosensory system is shut off to stop the visual signal generation. So the T-alpha subunit hydrolyzes GTP to GDP, and T-alpha reassociates with beta and gamma subunit. The inhibitory unit of phosphodiesterase is released. It associates with phosphodiesterase to cause it inhibition. So inhibition of phosphodiesterase leads to more cGMP concentration and opening of sodium ion gated channels and reversal of stimulation of rod cells. So active rhodopsin is prevented from causing prolonged activation of transducin by rhodopsin kinase. It leads to phosphorylation of serine and threonine residues of opsin. This is then bound by protein called arastatin 1, which prevents further activation of rhodopsin. Calcium ions also play a role in vision. During dark, calcium ions enter into the rods through cGMP gated channels along with sodium ions. The high calcium ion inhibits the guanylate cyclase that synthesizes cGMP. So it decreases cGMP levels and promote the generation of visual impulse. So next is the dark adaptation time. When we step from bright sunlight into a darkened room, say a dim cinema theater, we experience temporary blindness. But shortly, within a few minutes, the vision improves. This is due to regeneration of rhodopsin in dark. This phenomena is called dark adaptation. The time required for improved vision is called dark adaptation time. It is dependent upon vitamin A status and increases in deficiency of vitamin A. So next is the color vision. What is the role of vitamin A in color vision? So cone cells are responsible for vision in bright light as well as colored vision. So cone contain protein called canopsin or photopsin. So canopsin or photopsin is similar to opsin but not identical. The color vision is governed by color sensitive pigment porphyropsin red, iodopsin green and synopsin blue. All these pigments are retinal opsin complexes. When a bright light strikes the retina, one or more of these pigments are bleached depending upon particular color of light. Pigment dissociates to all trans retinol plus opsin, as in case of rhodopsin, and this reaction passes an nerve impulse to brain as a specific colored red when porphyropsin splits, green when iodopsin splits, or blue for synopsin. Splitting of these three pigments in different proportions result in perception of different colors by the brain. So next is the color blindness. So color blindness refers to inability to dissociate between different colors. For example, it is common defect. Many people are unable to differentiate between red and green. People suffering from color blindness either lack the red or green pigment in their cones completely or have them in abnormal forms, as a result of which they have trouble distinguishing red from green. The red and green pigment are up to 96% identical in their amino acid sequence, two genes for red and green pigment resides adjacent to each other on human X chromosome. So different type of color blindness occur as a result of different mutation in opsin. People lacking red pigment are called red dichromats, and those who lack green pigment are called green dichromat. It should be noted that color blindness is a genetic disorder and not a consequence of vitamin E deficiency. So other biochemical functions of vitamin A, first is the cellular growth and differentiation. So retinoic acid is implicated in cellular growth and differentiation by regulating the expression of several relevant genes. So this is seen in skin, epithelial tissues, and gonads. Abnormal keratinization of skin, conjunctiva, and reduced sperm count are seen in people with vitamin A deficiency. So next is vitamin A is essential for formation of mucopolysaccharides in extracellular matrix. Next is vitamin A is required for maintenance of healthy epithelial tissue. It maintains moist and pliable epithelium by inhibiting the synthesis of excess keratin. So retinol creams are used to treat acne, prevent wrinkles, and signs of age. So next, vitamin A is used in reproduction. So retinoic acid has a role in spermatogenesis. Retinol is required for normal reproduction. It is seen that vitamin A deficiency is accompanied by abortion and fetal reabsorption. So vitamin A has a role in as an antioxidant. So there is evident that beta carotene has a beneficial effect in preventing certain types of cancer and reducing the risk of MI. So beta carotene removes free radicals from tissues. Consumption of beta carotene in diet reduces the risk of lung cancer in chronic smokers. Beta carotene complements the antioxidant property of vitamin E. Unlike vitamin A, ingestion of large quantities of beta carotene is not toxic to the body. So next, vitamin A is essential for maintenance of immune system. Its deficiency causes keratinization of mucosal lining of respiratory, gastrointestinal, and genitourinary tract, making susceptible to frequent infections. So retinol and retinoic acid are essential for synthesis of transferrin, the iron transporting protein. Iron deficiency anemia may occur in vitamin A deficiency. So next is cholesterol synthesis require vitamin A. Mevalonate, an intermediate in cholesterol biosynthesis, is diverted for synthesis of coenzyme Q in vitamin A deficiency. So next is the recommended daily allowance. So RDA of vitamin A in case of men is 1000 RE, while in women it is 800 RE. So RE is the retinol equivalent. So daily requirement of vitamin A is high in growing children and women during pregnancy and lactation. Next are the dietary sources. So there are two sources, animal and plant. So in case of animal, liver, milk, egg, butter, cheese, fish, meat, they are the richer sources. In case of plants, green leafy vegetables such as spinach and amaranthus, papaya, pumpkin, mango, carrot are the good source of vitamin A. Next is the vitamin A deficiency. Common causes are poor nutritional intake, particularly of colored fruits and vegetables, liver diseases leading to inadequate storage and formation of bile needed for absorption of vitamin A. Next is malabsorption of fat, as vitamin A is fat-soluble vitamin. So lipoprotein abnormalities such as defective chylomicron synthesis, etc., which transport vitamin A along with the fats. So ocular manifestations of vitamin A deficiency, first is the night blindness, nitalopia, or inability to see in dim light is earliest symptom of vitamin A deficiency. It occurs due to impairment of dark adaptation. Next is the xerophthalmia. Night blindness, if left untreated, causes dryness of conjunctiva and cornea. The conjunctiva becomes thick and wrinkled. The cornea loses its mucosal cells and become dull and hazy due to keratinization and loss in transparency. Next are the Bitot spots. So Bitot spots are triangular white patches on the conjunctiva on either side of cornea. They are usually bilateral. So nyctalopia and Bitot spots are reversible with vitamin A supplementation. Next is the keratomalacia. If condition progresses beyond xerophthalmia, there is ulceration and necrosis of the cornea, which result in total blindness. So keratomalacia is a major cause of blindness in developing countries and usually associated with routine energy malnutrition. Next are the skin and mucosal membranes. So follicular hyperkeratosis of skin, also called phrenoderma, occurs due to increased keratin formation in follicles, leading to coarse, rough, and dry skin. So infection due to keratinization colonization of epithelial cells of gastrointestinal tract, urinary tract, respiratory tract. So vitamin A deficiency is associated with urinary stones. So in case of bones, there is thickening of skull bones and reduced remodeling. They are known to give rise to increased intracranial pressure, manifesting as vomiting, seizures, or even unconsciousness. So next are the gonadal dysfunction. So decreased spermatogenesis and increased abortions are known to be associated with vitamin A deficiency. This could lead to infertility. So next is the assessment of deficiency. So quite easily identified due to typical symptoms of night blind and follicular hyperkeratosis. Dark adaptation time is increased. Next is vitamin A levels are decreased in case of vitamin A deficiency. So there is vitamin A supplementation program. So in this program, target children aged are 6 months to 5 years. So first dose is given is 1 lakh international unit of vitamin A at 9 months. Then 2 lakh international unit of vitamin A is given at 6 to 18 months. Then it is given semi-annually till 5 years. So total of 9 doses are given. So in case of a therapeutic dose, if we have to give the treatment in case of vitamin A deficiency, so 2 lakh international unit is given immediately and it has to be repeated after 1 to 4 weeks. So next is the hypervitaminosis A. So what is hypervitaminosis A? It is excessive consumption of vitamin A which leads to toxicity, and symptoms are dermatitis, raised intracranial tension, enlargement of liver, skeletal decalcification, tenderness of the long bones, loss of weight, irritability, loss of hairs, which is also known as alopecia. Patient can have joint pains. Patient can have congenital fetal malformations due to higher intake in case of pregnancy. Patient can present with excessive sweating. Then patient have brittle nails. Patient can present with diarrhea. The problem with vitamin A derivatives is if they can cause growth and differentiation and they are lipid soluble, and if took them systematically they can go anywhere in the body. And the issue in pregnancy is, in pregnancy vitamin A derivatives could then cross the placental barrier and cause tremendous anomalies. So these anomalies would increase craniofacial issues, skin issues, liver issues, and so forth. So multiple tetragenicity, also bone problems can occur. So as such, vitamin A derivatives are also always contraindicated in pregnancy. So the contraindication is primarily for the drugs that are used systematically. A drug that is mentioned is the drug isotretinoin. So vitamin A derivatives may be used in the management of acne. So they should never be used in pregnancy because of teratogenicity. Next is famous translocation known as T1517 translocation, and other name is AML-M3 or acute myelogenous leukemia or promyelocytic leukemia. Because of those vitamin A receptors on promyelocyte, and because vitamin A can promote growth but also differentiation of cell, then that's going to be the basis for treating this AML-M3 with high doses of vitamin A. So vitamin A will take the promyelocyte, make it myelocyte, then take the myelocyte, make it into metamyelocyte, and then make the metamyelocyte, make it a band, and then make it a plain neutrophil. So from metamyelocyte onward, they cannot divide. So what your vitamin A did at high doses is force dividing cells that participate in leukemia to become finely matured cells that are no longer capable of proliferating. So vitamin A in AML-M3 is a classic question because of its translocation. So AML-M3 is generally present in young adults, someone between 15 to 39 years of age. It presents with the classic bone pains and aplastic condition from displacing the healthy cells. So it presents with infection, with a abrupt onset of fever. Big worry is that it has so many hour rods, which are these little lysosomes of the promyelocyte, that it can cause chemicals that trigger the actual damage to the vessel and multiple coagulation to form what we call DIC, disseminated intravascular coagulation. I hope you all understood vitamin A. Thank you so much.